Good day, dear colleagues. Please take your seats. It's our time to start our satellite symposium. BAUSCH&LOMB. We invite all who want to take participation in it, and we are very glad to communicate on this platform. And as to our agency, as to our agenda, the first report will be presented by Doctor of Medical Sciences, Head of Department of Pediatric Diseases, Bobrova Nadia Fedorina. Nadia Fedorina, the floor is yours. Thank you. Thank you. Today I will have a report. Simultaneous implantation of IOL and is a crucial part of cataract surgery. When we are talking about the eye of newborn, they have hypermetropic refraction, but there are different complications to establish the refraction, and it varies from 1.8 to 3.6 diopters. Not only the refraction data, but previous posterior anterior size of eye are not enough. As to the different authors, IOL implantation in newborn children is a discussable issue, and we have to dispute and to take as a resolution. There is an opinion that pars plana will be more effective than IOL transplantation. But look, as to the Lambert and limb data, phakia correction in newborn child is associated with the loss of contact lenses, difficulties in their substitution, development of bacterial keratitis, and it is very expensive. Manifestations for surgeries, form and size of IOL are the main pitfalls, and there is no one unique decisions among ophthalmologists. There are also different complications, and then growing of eyes and restoration of vision. For now, it is bad started and bad learned issue, because there were no big studies on this issue. I want to present you our data. We investigated and performed such surgeries on 100 children. Age is up to 24 months. The average age is 9.9. 74% were binocular forms. And you can see that the blue part is the full cataract. What are we talking about? Full binocular cataract. These children are fully blind. 38.9 are atypical. These children are also blind, and only 25.66 were cataracts with a big diameter of nuclei who have light sensitivity. Monoocular cataracts, we have only 25.8%, but look, 75 and 6% atypical cataracts prevail among those type of cataracts, and these are the most complicated cataracts for surgeries. So look at the general pathology of those inborn children. 83 So those children are not healthy. You can see that 55% is the pathology of central nervous system. Of course, there was secondary pathology of eyes, impairment of vision, but 18% was microphthalmos. Let's imagine eyes are small and children are small, plus microphthalmos. Examination methodology. We use general anesthesia. I won't enlist those methodologies. I want to show you those photos of atypical cataracts. And there are also factors that provoke uncertainty in calculations of IOL power in children. We have difficulties in measurement of axis length, then difficulties during investigation and fixation, and also it is very difficult to lay children in order to perform investigation. Different biometric and anatomic differences of pediatric eyes from adult eyes. So at this slide you can see that dry eye is not only is with a cataract, but it is also small compared to left eye. What are the average chronometry data? The smallest children from 0 to 3 months, 47.11 dioptries, and then we can see a decreasement due to the functioning of cornea. Average data of US biometry. Here you can see average data, and they also decrease with the age. So we understand that child are born with big eyes, and then there is organ genesis during 2 first years of life. In order to make a graftment into the sac, it is necessary into the capsule. It is necessary to understand where we can put this lens, because we use standard lenses for adults, and we began to measure diagonal measurement of capsular sac in our children, and you can see that in age from 1 to 3 months its dimensions were 6.5 millimeters. It is not enough for implantation, but in the age from 4 to 6 months is 6.8. We can try. A lens can be put there, and beginning with 7 months up to 24, the measurements of eye are increasing, and we are able to put IOL into this capsule. Here you can see all the data of pediatric eyes, and that gives us this possibility. We change the power of IOL, taking into consideration pediatric age. We decrease the dioptries. In the age from 0 to 12, we decrease from 5 to 16, and in the age from 12 to 24, from 8 to 12. Technique or surgery technique, it is classical, but what about pitfalls of our surgery in pediatric age? First of all, It's the first operation, first uninterrupted capsular access. We know that this proper performance of this procedure gives us chances to gain success in future. That's why we try to measure eyeball, and we plan the measurement and dimension of insection. And even in older children, the anterior capsular access is difficult to perform due to the increased elasticity of the anterior chamber of lens. And if we are talking about newborn children, this data was increased up to 11.8%. But despite these pitfalls, there were no rupture of posterior chamber. We can conclude that we can perform this surgery. Now I want to show you a small video. We color all the time. It's atypical cataract. You can see small central nuclei, and you can see that it goes to the periphery more than we planned, but we were succeeded in performing this surgery. Then hydrodissection, and then aspiration, very mild aspiration, because masses are soft as well as nuclear, but we have to make grafting here. But look, posterior capsule is opaque, and we incise it on the IOL. We use viscoelastics. It's our tactic in order not to impact, not to injure vitreous body. We performed it with the scissors. Why? Because there were different anomalies of lens development, and it was impossible to perform it in a classic way. Difficult in anterior capsular access in newborn, and the next procedures were connected also to the pupil rigidity and in other factors, as you see on those slides. We used iris retractors in order to dilate iris. Hyperplasia causes the removal of iris into postoperative wound, despite the small tunnel sizes. It is necessary to highlight that the surgery of inborn cataracts differs in problems from adults. It is difficult to perform surgeries when eye is small, and it is necessary to remember that it is still developing. Peculiarities of pediatric organisms should be taken into consideration. A big penetration of all barrier system, immaturity of all systems, increased insufficiency of immune response. So it can cause early and late sedative response of eye to surgery. And now I want to tell you about corticosteroid therapy, because we know that any surgery can't be performed without inflammation and without usage of corticosteroids, especially with the children of pediatric age. Here you can see local corticosteroids. They were studies loteprenol etoposide, and data were published about efficacy and safety. These studies were conducted during 2 decades in combination with another medications and alone. So we proved the conception of molecular design that is safe and it gives anti-inflammation and efficacy. LE is the basis for local therapy of wide spectrum of the different states after surgery. Why we see this picture? Because its inflammation efficacy is very high, then its lipophility is 10 times higher than dexamethasone, and its adjacent and possibility to connect by receptors and decrease the risk of complication development. Lotomax helps to restore endothelial cells to their normal exogen form in 74 hours after use, and it has anti-inflammation effect. Here you can see its form. It's a gel, 5% gel, for treatment of postoperative inflammation and pain syndrome. It has also special gel matrix to continue the exposition of main agent on the surface of eye. I want to tell you that it is this medication can be used beginning with the very born, because when we prescribed earlier steroids, they were prescribed after the age of 3 years, and these can be used beginning with the born of child. Then low TAP, combination of loteprenol and dexamethasone, in order to increase the treatment effect. It's loteprenol decapanate and lotepredsin 3 milligrams. And treatment form is drops. There were studies of administration, this combination lotepredol etoposide and tobramycin low TAP. Low TAP is more effective because it doesn't increase the IOP. Low TAP also has a high anti-inflammation and antimicrobial effect. It is very effective during first years of life because there is a great big contact with the hands. Then it increased the safety profile in diseases of first chamber anterior part of eye, and we can use it from 0 months. This formulation is not acceptable for me. So my conclusions, you can see on the upper right slide, very beautiful girl with 10 months old with inborn atypical cataract and her visual acuity is light sensitivity. You can see that the toy is big, and this girl doesn't respond to this toy. And you can see the result after the surgery. This photo was made in 3 days after the surgery. Visual acuity is not big, 0.03, but look at her behavior. She looks at the toy. And another one example, despite the conclusions, very severe problem, a boy 7 months old, full inborn cataract, so he was fully blind. Visual acuity, light sensitivity, how can we establish it? On the reaction response of pupil to light. Microcephaly is the secondary diagnosis, organic impairment of central nervous system, and there is no reaction of following. You can see a nurse is holding a boy and there is no response. And look at the lower slide, even the expression of his face changed. He's smiling. The result we got in 2 months after surgery. We performed IOL plus 25 dioptries. Visual acuity is very small, 0.012, but this child sees an influence on the development of his brain. Look at his behavior. He is thin, he is pale, but he wants to touch this toy and want to hold it. Thank you very much for your attention.
I think we will have the question session after the reports. So the next report is about pathogenesis and diagnostics of the disease. The Department of Eye and Lens Pathology, Dr. Ulyanova. Good day once again. I'm really happy that our hall is almost full. Today I offered to work about the issue of exfoliative or pseudo-exfoliative syndrome and its place on the way to state the diagnosis. For the first time, this pathology was described in 1917 by John Lindbergh. His scientific paper was dedicated to exfoliative syndrome, and he described it as often presence of grayish spots. What has changed during the recent years in our vision of exfoliative syndrome? So indeed, his description is the same as what we might see in microscopy, and what concerns terminology. Exfoliative syndrome is a chronic progressive disease which is followed by formation of fibrillar extracellular material in the tissues of the anterior segment of the eye. It is most often associated with age over 50, but during the recent decades it has been manifesting in younger patients. The pathogenesis base includes extracellular matrix functioning, of violations, and it has some association with genetic determinants and environmental status. So, if a patient has genetic or hereditary risk of this complication, it is in combination causes this pathology. A very scaleful research GIVAS found one nucleotide polymorphisms in the gene LOXL. What the fact that we have to differ exfoliative and pseudo exfoliative syndromes, we can observe it starting from the first stages of both conditions, where exfoliative syndrome is a disease associated with glass production when the change in the anterior capsule of the lens occurs and the anterior chamber of the lens starts disattaching. This is called exfoliation or scales, but if we speak about pseudo exfoliative syndrome, it's a completely different thing. But according to how they look like, they both look like scales covering the anterior chamber and on the iris. The changes of extracellular matrix and basal membranes of the internal organs are similar in all organs and systems. And truly, today, the pseudo exfoliative syndrome is not only an ophthalmological pathology, it's a systemic one. There has been lots of scientific researches uh, dedicated to pseudo exfoliative syndrome. Scientists have studied the lungs affected by this syndrome. There has been no direct association with eye syndrome and systemic syndrome. But we have noticed from the research that those people who drink coffee are more often having these types of conditions. Besides, the condition is depends on the geographical location of patients. Clinical manifestations with pseudoexfoliative syndrome are shown in iris, endothelium of cornea, especially if you do biomicroscopy layer by layer, you will find large increases the scales on endothelium. You will also notice these changes in trabecular, but most often the lens capsule and ciliary body have these scales forming. So retroluminescence shows the weakest parts of the iris. But if we speak about pseudo-exfoliative syndrome, it includes presence of pseudo-exfoliations in the anterior chamber of the eye, but lack of changes, lack of increased intraocular pressure. If we see a patient with glaucoma changes, changes in optical nerve disc, and increased intraocular pressure with scales. This tells us that the diagnosis is pseudo exfoliative glaucoma, which is a secondary form, most widespread, making up about 1/4 of all cases in the whole world. As compared to XFG, it is associated more with the intraocular pressure. Correction of intraocular pressure in this condition is less effective in case of usage of different medical preparations. It is considered that in cases of pseudoexfoliative glaucoma, there arises the flow of internal liquid and changes in the systemic nature, lesions of the vessels. And the optical nerve is not supplied in a normal way. Patients with this condition have the need of surgical treatment, and pseudoexfoliative glaucoma is often combined with cataract, and as a rule, meaning complicated forms of cataract, because these patients have high risk of subluxation, they have tears of the posterior capsules, they have keratopathies, they have small size anterior chamber and deficit of endothelial cells. And in complex, all these conditions, they increase the risk of complications after surgery. So such combination of pathological conditions causes possible complications intraoperatively. What should one take into account making surgery in patients with XFS? So we have to apply all the measures to dilute the pupil. We have to use capsule hooks in order to hold the sac. We have to avoid small capsular access because, first of all, it would complicate manipulations with the nuclear, and chemosis formation may increase. That's why large capsular access is a means of prevention of this problem. Besides, we have to perform hydrodissection delicately. Sometimes we have to implant the capsule ring or fixator. If we implant the ring, we recommend to fix it with a fixator. Fixing the intraocular lens. If we face something unplanned, then we make intravitreal surgeries. We are going to demonstrate videos with some of our clinical cases with mydriasis intraoperatively. Before the operation, we tried to dilute the pupil, but it could not. We could not reach the highest level of dilution. We tried to avoid damage of sphincter. We were trying to use the different techniques recommended, for example, by Americans, the techniques of rhombus, when one of the hooks is located under the basic section. But personally, for me, it was not comfortable enough, so I performed the cut underneath the iris retractor and attached we widened the pupil, but manipulations with the nucleus showed us that the capsule sac was unstable. That is why we fixed the sac with two capsule hooks to make it more stable and to perform vacuum-emulsification more safely. Here you can see cortical masses are extracted and internal intracapsular ring is placed. As to intracapsular rings, I would like to say that this is not a means of 100% success, but it helps for the sac to be placed more stably. In capsule, sometimes capsule rings do not help, and in that case one has to use fixation. Here in this video you can see that the patient had been already operated. The intracapsular ring was placed, but the complex tore off, and in this case we approached differentially in this case, without complete cyclodialysis. That is why we fixed the complex lens ring in the sac, fix it to the sclera by suture technique. You can see that the sac here is not bad, and partially the sac is holding, but anyway, we were there already, so we fixed it on 3 and 9 hours. That's an important issue. How to prevent such tears? How to make sure that the whole complex is not misplaced? We sewed with help of Sergienko-Kondratenko fixator, which has been demonstrated at conferences multiple times. Implantation of capsule ring makes it harder to extract cortical masses, but a little more time helps us to succeed. So this dissector is pulling the sac into the required position. In the second clinical video, we saw that the complex ring and IOL were in the pupil, whereas in this case you see that it fell on the fundus. In this new case, taking into account that we had to lift up the fibrosed ring, we decided to remove this capsule ring. It is implanted pretty easily, but not so easily removed. So this kind of phimosis is able to be formed in case of small capsulorhexis. This is how the tissue's properties are changed in pseudo-exfoliative syndrome. We proceeded with the next stage, remove the phimosis, because phimosis was so thick, so dense that it was pushing out. And as Professor Bobrova Nadia Fedorevna said, severe cases require adequate treatment. Speaking about pseudo-exfoliative glaucoma, we have to divide the treatment tactics to conservative and surgical one. We have to keep in mind that effectiveness of preparations is lower in primary glaucoma. The preparations of choice are those which decrease intraocular pressure by means of improvement of chamber moist removal. Also, conservative treatment means monotherapy as a rule um, is not enough. Surgical treatment includes laser, trabecular plastics, anti-glaucoma, surgical of both penetrating and non-penetrating type. Once again, commonly conservative therapy by preparations is not so effective in primary angular glaucoma. So please take a look at these examples of preparations with unique properties on account of metabolical properties of the molecule, which consists of latent prostone acid that improves the scleral passage for removal, and on account of work of these molecules, the use of these preparations for start therapy provides significant decrease of intraocular pressure, and patients with high level of intraocular pressure had it decreased to 40% level. We know that confirmation of success in glaucoma treatment is the opportunity to reach the aimed pressure in patients who used other hypertensive preparations first, but then switched to the new preparation therapy. 25% cases with Visalta treatment were successful and more effective. Indeed, use of these drops increases the volume of blood in the capillaries at the optical nerve and has, as everybody knows and as everybody probably prescribes to their patients, both preparations for control of intraocular pressure and preparations which support, let's say, functional condition of visual analyzer on account of citicoline, like cognizin, citicoline, cognizin. That's an important donator of citicoline, which provides the necessary components for patients with neurodegenerative pathology. That is why combination of cognizin with ABCD, vitamins and zinc can be used in all types of glaucoma, like pseudo, exfoliative, and others. This preparation contains antioxidants as well. It is really easy to use. It is pretty. It has a pretty nice taste. We have used it ourselves. the period of treatment can last about 12 weeks. To conclude, I have to say that pseudo-exfoliative syndrome is an age-related genetic determined system pathology based on formation and accumulation in tissues of various systems of organs of extracellular matrix, which is a result of elastomicrofibriopathy. Thank you very much.
Thank you, Nadia Anatolievna. And the next report, candidate of medical scientist, Dr. Petretska Oksana Stepanevna, retinal detachment with the open and close eye trauma. So you're welcome. Good day, dear colleagues. I want to present you my report, retinal detachment in open and close eye trauma. It's a detachment of non-sensory layers from epithelium. There is no one identification, and diagnosis is based on the past history. Traumatic detachment is 40% of all detachments. The frequency is from 0.5 to 2 to 100,000 of population. It can be both with the open and closed eye trauma. When the trauma is open, it is more widespread. When we are talking about open trauma, there is 30%, and also can be associated with the traumas of orbit and sclerotica chorioretinitis. And when we are talking about this disease, the data are lower than presented here in my report. But our work, scientific work that that was published in the scientific journal shows that retinal detachments are more widespread, and these are 54%. So development mechanism at the closed trauma looks like rheumatogenic detachment. We are talking about eyeball contusion. It's a rupture of eyeball, and then the detachment of retina. We have different complications after the rupture, vitreoretinal traction, and different injuries of vitreous body. There is a liquid in subretinal cavity and retina detachment. As a result, what are the types of detachment? When we see traumatic retinal detachment, these are flap ruptures, giant ruptures, and small ruptures. When we are talking about trauma ruptures, there can be multifocal and single focal ruptures. Detachments is developed during first 24 hours after trauma in the 24% of patients, and up to 2 weeks after trauma in 62% of patients. When we are talking about open trauma of eye, the mechanism of development differs. uh, traction, remote-genic traction prevails. Mm, And there are different traumas that can cause open trauma and provoke the retina detachment in 62%. When there is a penetrating wound with a sharp foreign body, 36%. And then when we are talking about foreign body, there is 16% and 36% in anterior and posterior parts of the eye, and then 2% of penetrating wounds. A video, please. Clinical case of penetrating wound of intraocular foreign body. You can see that foreign body is behind the eyeball, and here we can see retina rupture. And if vitreoretinal surgery performed timely, we can prevent retina detachment. So it's the most prominent case how to prevent retina detachment when to perform surgery in timely manner. Depending on the affected zone, 49% of detachment are due to the wounds of third zone, 31% when the second zone is injured. We are talking about the impairment of vitreous body because we have hemophthalmos and another complication, tractions, ruptures, and there is retina detachment. And unfortunately, when we have the injury of the first zone in 20%, 12%, we have the detachment of retina. Of course, when we have hemophthalmos in such a patients, practically 47 50% have retina detachment. The term of development are the next 27-30% in the first 24 hours after the penetrating wound of eyeball, and during the first weeks in a half of cases, and around 72% uh, it can develop during the first month after injury. And there are also long-term retina detachment when there were injuries of retina, vitreoretinal injuries, so it can be even in several years. There is a late rupture of retina, and it causes the retina detachment. Detachment can be local, subtotal, with the covering of macula and without covering of macula, and also total detachment. Symptoms and diagnostics. Of course, what we have, it's acute decrease in visual acuity, then there is opaque vision, and different impairments of visual acuity, loss of peripheral field of vision, and then central field of vision loss. We can dilate we can dilate iris and see the retinal uh, detachment. So when the trauma is closed, we recommend you to dilate uh, a pupil and to investigate on the subject of rupture and pre-rupture of retina. Because we can prevent detachment with the help of laser. It can, if we don't perform surgery in timely manner, we will lose the sight of our patient. And the most widely used method is surgery with 22 hertz. We can use UV diagnostics and we can see a local um, primary detachment just after the trauma. In 9% of patients, we can't establish their diagnosis before surgery. So these are 9% of cases of intraoperative detachment. What are treatment? It depends on the location of ruptures, then presence of foreign bodies, IOP. We are talking about pneumatic retinopexy, injection of gas. When we have ruptures of upper sides of retina, upper parts of retina, and ruptures of upper parts of eyeball, and after the attachment of retina, we perform laser coagulation through the gas bulb. Now we use this procedure rarely because now we are involved in battlefield traumas, and we don't use such a technique, but this technique is very useful. Local and circle extracircular surgery we use when we have vitreoretinopathy, when we have a macular rupture. In our institution, this surgery is widely used, despite the fact that not all the surgeons in Ukraine and all over the world like this procedure, but we have a high experience in this field. That's why we use this technique very often. It is very active, effective for patients who has such a data that I have mentioned. And when we are talking about traumatic detachment of different etiologies with big hemorrhages, proliferation, foreign bodies, and big ruptures, we use macro-invasive 3D vitrectomy in combination with a phaco IOL. We use nearly 76% of vitrectomy and combination of vitrectomy and focal sclera surgery. Clinical case you can see here. Local detachment of retina, and then you can see the trauma of lens. Also, you can see local detachment on periphery and on the very edge of periphery. You can see the rupture of retina. Of course, we use laser coagulation here and gas tamponade in such cases. Laser coagulation, you can see we have few such cases of local retina detachment, and because it's an urgent case, it's not a macular zone, so that's why a patient refers us because of increased IOP and his vision was high. Next clinical case, flap rupture of retina, peripheral as well, but not on the edge periphery, drainage of subretinal liquid, laser coagulation of retina. Practically the same example as previous one, but with a big flap rupture. Here you can see unfolded of retina and gas tamponade. The next clinical case, wound of sclera. It's a minor explosive trauma of eye, severe trauma. We examined sclera. It was unsealed trauma of sclera. It's a penetrating trauma. And we have the mixture of parts of eye. So we have to perform Luzon retinotomy to unfold retina and to use silicone tamponade. And combination of retinotherapy with a plastic surgery after the removal of all vitreoretinal attractions. The next clinical case, also the combination. It's the repeated retina detachment. Vitrectomy was performed earlier, but you see extrudes beneath the retina, so there was revitrectomy performed before this main surgery. We unfold the retina and perform silicone tamponade. In such severe cases, after such traumas, we prescribed medical therapy, antibacterial therapy, steroid medications, non-steroid gels, and antibiotics, of course, retinoprotective therapy. Floxal is very effective medication. Ofloxacin is a main agent. It's antibiotics of big sphere of action. Study was performed in Germany, and there was statistically significant decrease of microflora, especially to ofloxacin, from 11% to 7% in 2021. The main provokers of infections are sensitive to the main agent of this medication. It is produced in two forms as drops and ointment. Floxal is very is easy to use. There is no irritation in patients. One drop 4 times a day. Ointment has good adhesive effect. Maximum concentration of active agent is in 5 minutes after administration. Prescribed as a strip 3 times a day. And bromfenac, non-steroid anti-inflammation medication. and there was a study on the effectiveness of this preparation. The main sign, the main effect is inhibiting concentration, and it decreases the mediators of inflammation by 50%. So it increases the power of inhibition and the effectiveness of this medication. And also the cooperation of SOP1 and SOP2 is significant. It influences on the inflammatory action of this medication. You can see the effectiveness of bromfenac molecule in this medication, and it has the highest data in these highest points in this study. Sorry, it's the most effective anti-inflammatory medication among another non-steroid medications. Bromfenac helps us to absorb necessary concentration in all tissues of eye. And another one, medication, bromfenac molecule, its name is Yelox. It's a very powerful anti-inflammatory medication. It is the medication of Bausch plus Lomb 5 milliliter flask. And coronary gel we use after our operations. Eye gel with a concentration of dexpanthenol, and it helps us to heal the wound, to reduce the time of reepithelialization, and gel basis helps us to heal the wounded surface of eye. Detachment is a serious complication after the trauma, and it influences not only on visual results but on anatomic results of treatment. In order to restore vision after detachment, it is necessary to establish timely diagnosis and to choose the proper type of surgery. Vitrectomy is the main method of surgical treatment.
Дякую, Оксані.
Thank you, Oksana Stepanivna, and every lecturer who participated in the satellite symposium. I would like to thank the representatives of the company Bausch&Lomb, who I would like to see who is going to receive our certificate. The Institute of Eye Diseases, named after Filatov, expresses our gratitude to the representative of Bausch&Lomb company for your support in general and for the help in this conference. So we are moving further. The next section is trauma. Thank you.